Welcome, everyone. Today, we're diving into one of the most contentious medical topics making headlines right now, the claimed link between acetaminophen, better known as Tylenol, and autism spectrum disorders. This presentation will take you through a critical, evidence-based examination of the recent controversy that has medical professionals, families, and policymakers all asking the same question: should pregnant women avoid one of their safest pain relief options? We'll be examining this through the lens of evidence-based practice, looking at what the science actually tells us versus what we're hearing in the media and from government officials. Let's get started. Our agenda today covers 5 key areas that will give you a comprehensive understanding of this complex issue. First, we'll explore why this topic has suddenly become so controversial, focusing on the recent political announcement that has thrust this scientific debate into the public spotlight. Second, we'll dive deep into the scientific evidence itself, examining the key studies that both support and contradict a link between acetaminophen use during pregnancy and autism in children. Third, and this is crucial, we'll critically analyze the limitations of the existing research, because understanding what studies can and cannot tell us is essential for making informed clinical decisions. Fourth, we'll look at how the medical community and expert organizations have responded to these claims and why there's such a stark divide between political announcements and professional medical guidance. Finally, we'll discuss the clinical implications and evidence-based recommendations for healthcare providers and patients navigating this uncertainty. By the end of this presentation, you'll have the tools to critically evaluate the evidence and make informed decisions based on science, not headlines. So why has this issue exploded into the headlines? The answer lies in a high-profile political announcement that sent shockwaves through the medical community. On September 22, 2025, President Trump, flanked by Health Secretary Robert F. Kennedy Jr. and other officials, announced that the FDA would be issuing warnings about acetaminophen and autism. The administration claimed that acetaminophen may cause a very increased risk of autism and simultaneously promoted leucovorin as a treatment. This wasn't a quiet scientific paper or a medical journal publication. This was a major White House announcement with immediate policy implications. The timing was significant too. Kennedy had promised months earlier to identify autism causes by September 2025. But here's what makes this so concerning for healthcare professionals. The announcement generated immediate controversy among medical experts who dispute the strength of evidence supporting these claims. We're talking about a medication used by over 50% of pregnant women worldwide and autism diagnoses that affect 1 in 31 children in the United States. The potential impact is enormous. This has the power to affect millions of healthcare decisions, create unnecessary anxiety among pregnant women, and potentially lead to avoidance of safe, necessary treatment. The critical context here is that this announcement was made without presenting new data or scientific studies, creating a direct conflict between federal guidance and established medical consensus. Now, here's something crucial to understand about this whole debate. Autism diagnoses have absolutely skyrocketed over the past 25 years. In 2000, we were looking at 1 in 150 children. By 2010, that jumped to 1 in 68. By 2020, it was 1 in 36. And now, in 2022, we're seeing 1 in 31 children diagnosed with autism spectrum disorder. Those numbers are staggering, and they naturally make people want to find an explanation. But here's what autism experts will tell you, and this is important. The dramatic increase isn't because something new is causing autism. It's because we've gotten dramatically better at recognizing it. Look at what happened during this same time period. We got better screening tools. We broadened our diagnostic criteria with the DSM-5. We reduced the stigma, so more families sought evaluation. We expanded telehealth, especially during COVID. Each of these changes captured more children who would have gone undiagnosed in earlier decades. And here's the kicker. Acetaminophen use has remained relatively stable during this entire period. If acetaminophen was the culprit, you'd expect to see those usage rates climbing along with autism diagnoses, but that's not what we see. This disconnect is actually a major piece of evidence that challenges the whole premise of this controversy. To understand this controversy properly, we need to revisit acetaminophen's established clinical profile. For decades, we've recommended acetaminophen as the gold standard analgesic during pregnancy because it's earned FDA Category B classification and animal studies show no risk and we have extensive human safety data spanning over 70 years of clinical use. The clinical reality is stark. Acetaminophen represents our only safe, over-the-counter option for pregnant patients. NSAIDs carry well-documented teratogenic risks, particularly in the third trimester, where they can cause premature closure of the ductus arteriosus and oligohydramnios. When patients experience fever or significant pain, acetaminophen isn't just helpful, it's medically necessary. Untreated maternal fever, especially during the first trimester, has been linked to neural tube defects and other developmental abnormalities. The usage statistics underscore the scope of this issue. More than half of pregnant women globally use acetaminophen at some point during their pregnancy. We're talking about tens of millions of exposures annually. If there were a genuine causal relationship with autism, we would expect to see clear, consistent signals across multiple high-quality studies. This brings us to a critical clinical dilemma that every obstetrician and family physician now faces. The recent federal announcements create a direct conflict between established medical consensus and government health messaging. When patients ask us about acetaminophen safety, we're caught between decades of clinical evidence supporting its use and federal agencies suggesting otherwise. The risk of patients avoiding necessary treatment may actually exceed any theoretical risk from the medication itself. The evidence supporting an association does exist, and we need to examine it critically rather than dismiss it outright. The Mount Sinai meta-analysis, published in BMC Environmental Health just last month, reviewed 46 studies with data from more than 100,000 participants. Their conclusion was striking. They found what they termed strong evidence of association between prenatal acetaminophen exposure in both autism and ADHD. The researchers used the navigation guide methodology, which is considered a rigorous framework for evaluating environmental health evidence. They noted that higher quality studies were more likely to show positive associations, which initially seems reassuring for their conclusions. Several Harvard and Nurses Health Study cohorts have contributed to this literature over the years. These are well-established research populations with detailed covariate information and long-term follow-up capabilities. Some have suggested dose-response relationships, with longer duration of use showing stronger associations. The proposed biological mechanisms aren't implausible either. Acetaminophen could theoretically affect fetal brain development through oxidative stress pathways, hormonal disruption, or epigenetic modifications. Animal studies have shown some concerning effects on neurodevelopment, particularly with prolonged exposure during critical developmental windows. However, and this is crucial, association is not causation. These studies demonstrate statistical correlations, but correlation and causation are fundamentally different concepts in epidemiology. Multiple confounding factors could explain these findings without acetaminophen being the actual culprit. The challenge is determining whether these associations represent true causal relationships or simply reflect unmeasured variables that influence both medication use and autism risk. The contradicting evidence is where this story gets really interesting, particularly when we examine study methodology and quality. The Swedish national study published in JAMA last year represents the highest quality evidence we have on this question. This wasn't a small cohort study. They followed 2.5 million children born between 1995 and 2019, with 185,000 exposed to prescription acetaminophen during pregnancy. Initially, their results seemed to support the association hypothesis. They found a small increase in autism rates, about 1.42% in exposed children compared to 1.33% in unexposed children. That's a difference of 0.09 percentage points, which sounds minimal, but could be statistically significant with such large numbers. Here's where the methodology becomes critical. The Swedish researchers conducted sibling pair analysis comparing children born to the same mother where acetaminophen was used in one pregnancy but not another. This approach controls for shared genetic factors, family environmental influences, maternal health patterns, and socioeconomic status, variables that traditional population studies cannot adequately address. When they applied sibling controls, the association completely disappeared. This finding is methodologically robust and suggests that initial associations were due to familial confounding rather than acetaminophen exposure itself. A 2025 Japanese study with over 200,000 children used similar sibling comparison methodology and reached identical conclusions. No association between acetaminophen and autism when controlling for family factors. The Obstetrics and Gynecology Review from earlier this year synthesized 9 high quality studies and 3 meta analyses, concluding that acetaminophen is unlikely to confer clinically important increased risk and recommended no changes to current clinical guidelines. The authors specifically highlighted how associations weaken or disappear when more rigorous controls are applied. The methodological limitations in existing research are so fundamental that they undermine confidence in positive findings. The primary issue is confounding by indication. The medical conditions requiring acetaminophen treatment may themselves increase autism risk, not the medication. Maternal infections during pregnancy increase autism risk by approximately 30%, according to multiple studies. When women take acetaminophen for fever or pain, we cannot separate the effects of the underlying infection from the medication effects. Most studies claiming positive associations fail to adequately control for this critical confound. Selection bias affects many cohorts. Women who report acetaminophen use may differ systematically from non-users in ways that affect autism risk, education levels, healthcare seeking behavior, pregnancy complications, or underlying health conditions. These differences could explain observed associations without implicating acetaminophen. Recall bias is pervasive in studies relying on maternal self-report years after pregnancy. Mothers of children with autism may be more likely to remember and report medication use during pregnancy, creating artificial associations. This is why prescription registry studies, despite their limitations, provide more reliable exposure data. The effect sizes reported in positive studies are remarkably small, often less than 1/10 of a percentage point difference in autism rates. These tiny effects could easily result from measurement error, unmeasured confounding, or statistical fluctuation, rather than true causal relationships. Publication bias likely favors positive findings. Studies showing associations are more likely to be published than those finding no effect, skewing the apparent weight of evidence. Multiple comparison issues arise when researchers test numerous exposure windows, doses, and outcomes without appropriate statistical corrections. When you combine these methodological concerns with the disappearance of associations in sibling-controlled analyses, the case for causation becomes extremely weak. The medical community's response to Monday's announcement has been swift and unequivocal. Major professional organizations didn't mince words in their criticism. The American College of Obstetricians and Gynecologists called the announcement highly unsettling and emphasized it lacked backing of reliable data. This wasn't diplomatic disagreement. This was professional societies directly challenging federal health policy. The Autism Science Foundation went further, calling the announcement dangerous and expressing deep concern about its potential impact. Their statement emphasized that any association between acetaminophen and autism is based on limited, conflicting, and inconsistent science. International responses have been equally dismissive. The Society of Obstetricians and Gynecologists of Canada reaffirmed acetaminophen as first-line therapy when medically indicated. The European Medicines Agency stated there's no new evidence requiring changes to current recommendations. What's particularly striking is the consistency of opposition across different medical specialties and countries. Obstetricians, pediatricians, epidemiologists, and autism researchers are all reaching similar conclusions independently. Expert epidemiologists who have actually studied this question are openly questioning the administration's approach. Dr. David Mandel from University of Pennsylvania noted that the evidence was really mixed and the effects were really small. Dr. Brian Lee from Drexel University, who led the Swedish study, expressed confusion about how the administration reached different conclusions than the scientific community. This level of professional pushback against federal health announcements is unusual and reflects genuine concern about the scientific basis for these recommendations. Now we turn to the most important piece of evidence in this entire debate, the Swedish national study published in JAMA last year. This represents the gold standard for epidemiological research on acetaminophen and autism, and understanding its methodology and findings is crucial for clinical decision-making. The study design was population-based cohort with sibling controls, the most rigorous approach possible for this research question. They analyzed 2.48 million children born between 1995 and 2019, with 185,000 exposed to prenatal acetaminophen. The follow-up period extended up to 24 years, providing unprecedented statistical power and temporal scope. Their initial findings seemed to support concern. They found a small increase in autism rates among exposed children, about 0.09 percentage points higher than unexposed children. In absolute terms, that's 1.42% versus 1.33% autism rates. With such large numbers, this difference was statistically significant. However, the sibling pair analysis completely changed the picture. When comparing siblings born to the same mother, one exposed to acetaminophen, one not, the association disappeared entirely. This methodology controls for shared genetic factors, family environmental influences, maternal health patterns, socioeconomic status, and countless other variables that traditional population studies cannot address. The disappearance of association in sibling analysis strongly suggests that initial findings resulted from unmeasured confounding rather than causal effects of acetaminophen. The study also found no dose-response relationship and similar null findings for ADHD and intellectual disability. This represents the highest quality evidence available on this question, with excellent statistical power, rigorous methodology, and findings that directly contradict claims about acetaminophen causing autism. The Mount Sinai meta-analysis deserves careful scrutiny, given its prominent role in recent federal announcements. Published in BMC Environmental Health just last month, this systematic review examined 46 studies with data from over 100,000 participants, using the navigation guide methodology. The authors concluded there was strong evidence of association between prenatal acetaminophen exposure and neurodevelopmental disorders. On the surface, this appears comprehensive and rigorous. The navigation guide is indeed a respected framework for evaluating environmental health evidence. The sample size across studies was substantial, and the authors claimed higher quality studies were more likely to show positive association. However, several critical concerns undermine confidence in these conclusions. Most significantly, the senior author, Dr. Andrea Baccarelli, served as a paid expert witness in litigation against acetaminophen manufacturers. This creates an obvious potential conflict of interest that could influence study selection and interpretation. The methodology raises red flags as well. The analysis excludes the Swedish study, the largest and highest quality research on this topic, without adequate justification. When your meta-analysis omits the best available evidence that contradicts your conclusions, questions arise about selective inclusion criteria. The heterogeneity among included studies was substantial, combining different study designs, exposure measurements, and outcome definitions in ways that may not be methodologically sound. This appears to be cherry-picking favorable studies rather than comprehensive evidence synthesis. The Obstetrics and Gynecology Review, published earlier this year, provides a different perspective, authored by recognized teratology experts who focused specifically on study quality rather than quantity. They selectively reviewed 9 high-quality studies, plus 3 meta-analyses, applying rigorous criteria for outcome definitions and methodological soundness. Their conclusion was measured but clear. Acetaminophen is unlikely to confer clinically important increased risk of neurodevelopmental disorders. They noted that associations consistently weaken when studies control for familial confounding factors, suggesting that positive findings in other research reflect unmeasured variables rather than causal relationships. These authors brought particular expertise to the analysis. They're internationally recognized specialists in teratology and birth defects research. Their assessment focused on studies with the most rigorous diagnostic criteria and longest follow-up periods. The review identified important biases in studies showing positive associations, including inadequate control for indication bias and failure to account for genetic factors. They specifically highlighted how sibling-controlled analyses consistently show weaker or null associations. While this was a narrative rather than systematic review, the author's selective focus on methodological quality provides valuable counterpoint to analyses that include all available studies regardless of quality. Their recommendation that current evidence doesn't support practice changes reflects careful consideration of both scientific rigor and clinical implications. The Harvard and Nurses Health Study cohorts have contributed significantly to this literature, and we need to understand both their strengths and limitations. These are well-established research populations, the Nurses Health Study 2 and Boston Birth cohort, with detailed covariate information and good long-term follow-up. The prospective design of these cohorts reduces recall bias compared to case control studies. Nurses are generally reliable reporters of medical information, and the detailed questionnaire data allows for adjustment of multiple potential confounders. Several publications from these cohorts have reported modest associations between acetaminophen use and autism or ADHD. However, critical limitations affect interpretation. Exposure assessment still relies on self-reported medication use, which introduces measurement error. More importantly, these studies cannot adequately control for confounding by indication, separating medication effects from the underlying conditions requiring treatment. The cohorts also lack sibling controls, which we've seen are crucial for eliminating familial confounding. The study populations are somewhat homogeneous, primarily educated healthcare workers, which may limit generalizability to broader populations. While these studies provide valuable data, they cannot establish causation. The observational design and inability to control for key confounders mean that modest associations could easily reflect unmeasured variables rather than true causal relationships. The absence of sibling controls is particularly problematic given what we've learned from the Swedish research. Examining additional key studies reveals a consistent pattern. Studies with better methodological controls consistently find weaker or no associations. The Avella Garcia European cohort study from 2016 found increased ADHD symptoms, but couldn't control for confounding by indication. The Norwegian study by Estrom showed initial associations that weakened substantially in sibling analyses. Several Danish registry studies reported associations with behavioral outcomes, but these used behavioral rating scales rather than clinical diagnoses and couldn't separate medication effects from underlying maternal conditions requiring treatment. Smaller, well-controlled studies like the Thompson cohort from 2014 found no associations, but lacked statistical power due to smaller sample sizes. Japanese studies using sibling comparisons consistently show null findings. This pattern is methodologically informative. Studies showing positive associations typically lack adequate controls for familial confounding, cannot separate medication effects from indication for use, or rely on behavioral outcomes rather than clinical diagnoses. Studies with more rigorous designs, particularly those using sibling controls or larger population-based samples, consistently find weaker effects or no associations. The Bradford-Hill criteria for establishing causation are not met by current evidence. Effect sizes are small and inconsistent, dose-response relationships are unclear, and temporal relationships are complicated by indication bias. Most critically, the strongest associations disappear when familial confounding is controlled through sibling analysis. This pattern suggests that positive findings in earlier studies reflect methodological limitations rather than true causal relationships. When we apply standard evidence hierarchy to this question, the picture becomes clear. Systematic reviews and meta-analyses typically provide the highest level of evidence, but the acetaminophen literature shows mixed results with significant methodological concerns. Randomized controlled trials aren't feasible or ethical for this research question. The highest quality evidence comes from large cohort studies, particularly those with sibling controls. Here, the Swedish study stands out. It found no association when properly controlling for confounding factors. This represents level 3 evidence of the highest caliber. Pastoral studies and smaller cohorts have shown some positive associations, but these represent moderate quality evidence with important limitations. Applying Bradford-Hill criteria for causation reveals major gaps. The strength of association is weak and inconsistent across studies. Dose-response relationships haven't been clearly demonstrated. Temporality is complicated by indication bias. We can't separate medication timing from the conditions requiring treatment. Consistency is lacking. The highest quality studies show no effect, while lower quality studies show modest associations. Biological plausibility exists, but coherence with other evidence is poor. The criteria for establishing causation simply aren't met by current evidence. This doesn't prove acetaminophen is completely harmless, but it means we cannot conclude it causes autism based on available data. The disconnect between federal announcements and professional society recommendations creates unprecedented confusion for clinicians. Major medical organizations maintain their long-standing positions supporting acetaminophen safety during pregnancy. ACOG continues to recommend acetaminophen as the safest analgesic option when medically indicated. The Society of Obstetricians and Gynecologists of Canada reaffirmed their position immediately after Monday's announcement. The World Health Organization maintains that acetaminophen remains safe for pregnancy use. Meanwhile, the FDA is now issuing physician warnings despite decades of supporting acetaminophen safety. This represents a dramatic shift in federal policy without corresponding changes in the underlying science. The current evidence-based principles remain sound. Use the lowest effective dose for the shortest duration necessary under medical supervision when benefits outweigh risks. Non-pharmacological approaches should be tried first when appropriate. However, we face a clinical dilemma. Professional medical societies support continued use based on scientific evidence, while federal agencies suggest caution. This puts practitioners in the difficult position of choosing between professional consensus and government guidance. The situation requires clear communication with patients about the strength of evidence and the reasoning behind our recommendations. The current messaging creates several potential harms that we must consider. Maternal guilt represents a significant concern. Women who use acetaminophen during pregnancy may experience unnecessary anxiety and self-blame. This psychological burden serves no productive purpose, given the weak evidence for causation. More concerning is the potential for treatment avoidance. If pregnant women avoid acetaminophen for fever or severe pain, they face real medical risks. Untreated fever poses documented dangers to both mother and fetus. Pain management affects maternal wellness and potentially fetal development. Some patients may turn to contraindicated alternatives like NSAIDs, creating genuine harm from misguided risk avoidance. Emergency departments and obstetric offices are already reporting increased calls from anxious patients seeking guidance. The autism community raises valid concerns about stigmatization. Messaging that focuses on preventing autism can inadvertently reinforce negative perceptions of autistic individuals. This othering diverts attention from support, acceptance, and quality of life improvements. Communication best practices require acknowledging uncertainty while avoiding definitive claims lacking strong evidence. We should emphasize individual consultation and avoid broad prohibitions based on weak association. The challenge is balancing appropriate caution with recognition that fear-based messaging can cause more harm than the theoretical risks it aims to prevent. Future research should address current limitations rather than simply generating more studies with similar methodological flaws. We need prospective studies that can separate acetaminophen effects from the underlying infections and conditions requiring treatment. This represents the most critical gap in existing literature. Larger sibling-controlled studies would provide additional confidence in null findings from the Swedish research. Better exposure assessment through biomarkers or more detailed medication tracking could improve precision. Investigation of genetic susceptibility factors might identify subpopulations at higher risk, though this approach requires enormous sample sizes to detect interactions. Biological research should focus on mechanism studies using appropriate models, biomarker development for risk stratification, and pharmacokinetic research specific to pregnancy. The NIH Autism Data Science Initiative announced this week will fund 13 projects totaling more than $50 million. This represents a systematic approach integrating genetic, environmental, and clinical data using advanced analytical methods. However, realistic timelines matter. High-quality studies addressing current limitations will take 5 to 10 years to complete and may not provide definitive answers given autism's complex etiology. Research should also focus on proven interventions, early detection, effective therapies, and support systems, rather than continuing to pursue weak environmental associations that may never yield actionable findings. Given the current evidence, our clinical recommendations should remain grounded in science rather than political announcements. For healthcare providers, the path forward is clear. Continue current evidence-based practice. Acetaminophen remains the safest analgesic option during pregnancy when medically indicated. Shared decision-making becomes crucial in this environment. Discuss the conflicting messages patients may have heard, acknowledge the uncertainty in the literature, but emphasize that the highest quality evidence doesn't support causation. Document your clinical rationale thoroughly given the current controversy. When counseling patients, key messages should include current evidence doesn't establish causation between acetaminophen and autism. Untreated fever poses documented risks to both mother and baby. No safer alternatives exist during pregnancy, and medication should be used at the lowest effective dose for the shortest duration needed. Specific indications remain unchanged. Fever above 100.4 degrees Fahrenheit, moderate to severe pain, and situations where non-pharmacological measures prove insufficient. Always provide guidance within the context of individual patient assessment. Watch for concerning patterns in your practice, patients avoiding necessary medication due to fear, use of contraindicated alternatives like NSAIDs, untreated maternal fever or severe pain, and excessive guilt about past acetaminophen use during pregnancy. What do we actually know with confidence? Acetaminophen has decades of established safety data during pregnancy. It represents the only safe over-the-counter analgesic option we can recommend. Untreated fever creates documented risks for both mother and fetus. Autism has strong genetic components that explain the majority of cases. The areas of genuine uncertainty include the true magnitude of any risk, if one exists at all. Biological mechanisms remain theoretical, individual susceptibility factors are unknown, and optimal dosing strategies haven't been definitively established. Critical evidence gaps persist throughout this literature. No high-quality studies prove causation between acetaminophen and autism. The largest, best-controlled study found no association when familial factors were considered. Confounding by indication remains unresolved in positive studies. Effect sizes, when detected, are remarkably small and inconsistent. The fundamental conclusion from our evidence review: current research doesn't support avoiding acetaminophen when medically indicated during pregnancy. The documented risks of untreated fever and pain likely outweigh any theoretical risks from judicious acetaminophen use. This represents evidence-based medicine in practice, acknowledging uncertainty while making recommendations based on the best available data rather than speculation or political pressure. Thank you for your attention. The evidence is clear. The highest quality research found no causal link between acetaminophen use during pregnancy and autism when properly controlling for confounding factors. Continue evidence-based practice. Acetaminophen remains the safest analgesic option during pregnancy when medically indicated. Our clinical decisions should be guided by scientific evidence, not political announcements. Evidence-based practice requires careful evaluation of all available data and commitment to patient safety above all else.